So, Sherry, embedded in the Affordable Care Act, I mean, I think people know the broad strokes, and I would say, I think America is far more conscious of the broad strokes of what the Affordable Care Act, and we should say the Patient Protection Affordable Care Act, because I think people are becoming more and more aware of the patient protections involved in what we now call Obamacare. But within the sort of major pillars, the expansion of Medicaid, the regulations on what constitutes actual health insurance, sort of a baseline for these things, and then the subsidies involved in the exchanges. There are a lot of different pilot programs, and that's the one that you write about that is taking place in Missouri. And welcome to the show.
Thank you. Thank you, Scott. I appreciate that.
So tell us about this story in Missouri.
Well, the story in Missouri is actually a reflection of many things that started happening around the country that were funded by the Affordable Care Act several years ago, actually 2009, 2010, 2011. This program was an integrated care experiment that was funded for Medicaid patients that are often called the 550, the 5% of patients who use 50% of medical care and can cost in some communities up as much as $10,000 a year in ER costs and hospital costs. And in this case, people who also were struggling with serious mental illness. These types of innovations, these types of programs were a key part of the ACA. This one, I believe, was done through the Social Security Administration. There are others that were largely done through the Centers for Medicaid and Medicare Innovation Center, which is still alive, but there is a question about how long it may be. And there were efforts to reform payment models and give people better care.
So, all right, let's start with this 550 designation. Now, I've heard of that dynamic a lot more as of late. And for many years, we heard that basically 80% of healthcare costs are borne by 20% of the population. And this is, I guess, a subset of that 20% population, which bears an even greater percentage of cost. So let me ask you this, and then I want to go through, like, what that person, that profile of a person, what would cause that person to be requiring so much care. But when we talk about the United States as being much more expensive in terms of healthcare per capita, is it because that 5% exists and doesn't exist in other situations? Is it because the care for that 5% is that much more expensive? Is it because we lack preventative care that would undercut that, or does it, I guess, maybe speaks to the success of this program as where the sort of the delta is between that 5% in this country and that 5% in, say, Canada?
Yeah, I would like to say that these people, people who have, in this case, that 5% is usually defined by 2 or more chronic health conditions. Say they have heart disease, diabetes, and hypertension. And in the case of this program, they're also struggling with a serious mental illness. That is, even if it's depression, but serious enough to require medication. Washington Monthly Magazine specifically asked me to investigate and to look at programs for that group. That's how they're defined, but these people are, of course, all over the world. The big answer as to why it costs too much, that is the billion-dollar question. I suspect that it is how we care for people in the United States, how we charge for care, and the lack of a support network for people who really need it, which is what these programs reveal, which is what the difference is in the health indicators and the health quality and the life quality of these people when they do get that support. but it's a very special kind of support. It's very rare in the United States. It might be that that support is more available in a country where there might be universal care or where social services might be easier to access, because in this particular case, all of these people are Medicaid patients.
And it's a fascinating story. You focus on a woman, Pat Powers, and her treatment at the Crider Health Center in St. Charles, Missouri. And you really do get a sense of what can go wrong when you have a patient who is taking so many different medications, but they're coming from so many different sources in some ways.
Yes, and so she had a mental health provider who had no relationship with her primary care provider. They didn't know each other. She was initially trying to juggle several part-time jobs to hold herself together, which was making her anxiety disorder and depression and other psychological issues more difficult to manage. And on top of that, she was trying to manage diabetes and weight and the medication for her behavioral disorders all on her own. She eventually couldn't deal with the job, which meant not being able to keep up with the insurance, which meant not being, I think she might have briefly lost housing, though she has housing now. It just came apart. It requires a great deal of attention. One of the care providers that I interviewed, Nancy Gongaware, who is a nurse navigator in this system, said, just think of how much it takes for a person whose life is completely together to just manage diabetes.
Right.
Not diabetes and hypertension and potentially obesity, which, by the way, weight gain is exacerbated by the kinds of medications that manage some forms of mental illness. It changes your body's ability to gain weight, and then you're managing anxiety, and then you're managing depression, and you're trying to hold down a job.
And I would imagine there are reactions between the medication, too. I mean, if you don't have the same person who is prescribing them or isn't aware of what's being prescribed, and you have a patient who is having a tough time sort of maintaining the different medications that they're supposed to be taking or that they are taking, that I imagine these interactions become a problem.
Yes, one of the things they do, this is a patient-centered medical home demonstration, and they were carried out all over the country, and hopefully they will continue to be. One of the key aspects of a medical home is to make sure that providers caring for a person interact with each other and share medication information and share information about hospitalization, so that a behavioral health provider, for example, knows when someone ends up in an ER. And so that they don't have this situation where a person is being over-medicated or having interactions.
Okay, well, we're going to take a break, and when we come back, I want to talk about the specifics of this pilot program and this grant that Missouri got, and I want to talk about why they're getting a pilot program for Medicaid when they didn't accept the expansion of Medicaid in that state. We got to take a quick break. We'll be right back. We're talking to Sherry Crute from she's written a piece for the Washington Monthly, how an obscure Obamacare provision is quietly saving lives and money in Missouri. I'm Sam Seder. This is Ring of Fire. We'll be right back after this.